Good morning, everyone. So I'll be presenting my study on the comparative analysis of iris glow lens implantation. So the objective is to analyze the visual outcome, the intraocular pressure profile, complications, post-retropupillary iris glow lens fixation in complicated cataract surgery-induced aphakia, and also to compare the results of retropupillary iris glow lens fixation in eyes with and without anterior vitrectomy, and also to compare the results in eyes with and without a surgical peripheral iridectomy. So the hypothesis is that iris glow lens implantation has emerged as one of the most safest and preferred method to correct the surgical aphakia in complicated cataract surgery patients, and studies have shown that anterior versus retropupillary fixation yielded similar results and complication profile. However, the retropupillary fixation is more advantageous because it respects the physiological location of the lens within the eyes. So routinely, anterior vitrectomy is performed by most of the surgeons during a retropupillary iris glow lens prefixation. However, there are few surgeons who may not do that if the anterior vitreous phase is undisturbed or there is no vitreous in the pupillary margins. However, what is the chances of IOP spike, the secondary inflammation, recurrent uveitis, visual prognosis in such cases without an anterior vitrectomy is not studied yet. Also, there are few surgeons who implant an iris glow lens without a surgical PA. However, there are no studies comparing the effect of PA in the long-term IOP profile also. So, when we did a literature search, we found that a comprehensive literature literature review yielded that most of the studies were comparing iris glow lenses with anterior chamber IOLs and SF IOLs. And the results, early studies were mainly comparing the results with anterior pupillary iris glow lenses rather than retropupillary iris glow lenses. So, there is an increased need for more studies focusing on the retropupillary iris glow lenses. Primary outcome is the long-term visual outcome and the complication profile in this RPICL implanted patients in comparison of the IOP and complication profile in with and without anterior vitrectomy, and also the chances of IOP rise and complications in eyes without a peripheral iridectomy. So it was a retrospective study from July 21 to 2023. We included all complicated cataract surgery patients with intraoperative posterior capsular rupture, sonlar dialysis, pre-existing dialysis with at least a 3-month of follow-up. We excluded all cases with gross iris abnormalities, iris new vessels, and uveitis and pre-existing glaucoma. So all the demographic data was collected. All the patients underwent a complete ophthalmological evaluation, including best corrected visual acuity, slit lamp examination, A scan, central corneal thickness, intraocular pressure, and a complete fundus evaluation. Categorical and quantitative variables were expressed as frequency and mean plus standard deviation respectively. Independent t-test was used to compare the quantitative parameters between the characters. So we had a total of 36 eyes of 36 patients. Mean age was 68. Group A, that is one with anterior vitrectomy, included 18 eyes, and Group B, that is the one without an anterior vitrectomy, included 18 eyes. Mean best corrected visual acuity is 1.6 unit, which improved to 0.33 at the end of 3 months in the total study group. Mean IOP of the study population was 15 millimeters of mercury. Best corrected visual acuity in our study improved significantly in both the groups after surgery and was remarkably higher than the baseline. There was no statistically significant difference in the best corrected visual acuity between the two groups during each follow-up visit. The mean intraocular pressure was highest on day 1 and it was around 22 millimeters of mercury. The mean postoperative IOP at the end of 3 months was 14. An IOP greater than 21 millimeters of mercury was noted in 10 patients in Group A and 11 patients in Group B at the first week postoperatively. However, there was no statistically significant difference between the observed IOP between the two groups. Complications, when we compared the complication, the Group B, that's the group without an anterior vitrectomy, did have a higher rate of postoperative transient IOP rise, recurrent iritis, pupil ovalization than the Group A, but the difference did not come statistically significant. Disenclavation of iris glow lenses happened in case 1 patient in Group A, whereas in 2 cases in Group B. And complete ICL dislocation also happened in 1 case in Group A. Significant corneal edema was actually more in the Group B, that is the eyes without an anterior vitrectomy. Coming to the surgical PA, primary surgical PA was actually done only in 14 eyes. Rest of the eyes, the surgical PA was not done. However, the need for a secondary laser PA due to an uncontrolled IOP postoperatively happened only in 3 eyes. So we conclude that there is no statistical significant difference in the IOP profile between the two groups with and without PA. So this is in discussion. Study by Crystalline et al. And Dalby et al. Claim equal efficacy of RPICL when compared to secondary IOL. And a study by Madhivanan et al. Also claims equal efficacy and safety for RPICL. However, they stated that the incidence of iritis, transient IOP rise, ovalization was all higher in case of RPICL implantation. So our study also showed that RPICL implantation is a safer and simpler method. But the BCVA and IOP profile is comparable with SFIOL. In cases with complicated cataract surgery and with very less vitreous disturbance or no anterior vitreous phase disturbance, it is actually safe to do a iris flow lens implantation even without an anterior vitrectomy. Postoperative IOP profile, post-retropupillary iris flow implantation without iridectomy was similar. Thank you.
Yeah, so you said that the intraocular pressure profile was similar, right?
Yes, sir.
So you also said that 3 patients required a YAG-PI for uncontrolled IOP. Was
Yes.
that in the vitrectomy group or in the non-vitrectomy group?
It was in the non-vitrectomy group, sir.
So you had 18 patients in the vitrectomy group and 18 in the non-vitrectomy group.
Yes, sir.
You did surgical PI in 14 patients.
Mm.
Was this in the vitrectomy group or non-vitrectomy group?
That,
Even assuming that it's
yeah.
equally distributed,
Mm.
that means you had 11 patients who did not have a surgical PI in the non-vitrectomy group, out of which 3 had an acute IOP spike which needed a YAG PI.
Yes,
So
sir.
3 out of 11 is 30%. So when you look at mean values and compare this, your study is not powered to pick up the differences. One. Second, you are trying to, the only aim of your study, of doing the PI is to prevent a pupillary block.
Yes, sir.
So you actually have to look at the rates of pupillary block in both the groups.
Yes.
And the rates of pupillary block are very high in your study, is 35%. So concluding that, doing a PI is not of any use is actually misleading when you interpret it like that.
Okay.
What were the situations where you did not do anti-vitrectomy?
Sir, actually, most of the cases where this black, brown cataracts, very hypermature type. So in those cases, actually, even though the lens came with the bag and sometimes there was SEDI also, we found that the anterior vitreous phase was not disturbed. There was not much vitreous coming
Any
up.
modification of iris claw implantation you did in such cases? Because what happens, even the implantation of iris claw itself can disturb the anti-vitreous space.
Yes,
Because
sir. But actually, in our cases, like
that's
it's
what
done
I'm
by senior
asking.
surgeon.
That's what I'm asking. Any modification?
No, it was done by senior surgeon. But
Okay.
not me.
Okay. Thank you.